Okay, let's jump right into this explainer because we are about to completely dismantle everything you probably assume about how humans experience pain. Seriously, most of us just think of pain as a basic alarm bell, right? But modern science shows it's actually an incredibly complex, fascinating puzzle. Today we're going to look at the hard data and some wild historical cases that literally forced a total paradigm shift in the medical community.
So, let me ask you something right off the bat. Is it physically possible to feel extreme, debilitating, absolutely agonizing pain without a single scratch on your actual body? Now, if your gut instinct is to say, no way, well, you're definitely not alone. But history and science have totally proven otherwise.
Picture this. It's 1995, and a 29-year-old builder rushes into the emergency room in absolute agony. He had just jumped down and landed right on a 15-centimeter nail. It punched straight up through his heavy work boot. Any tiny movement? Excruciating. The guy was in so much distress that doctors actually had to heavily sedate him just so they could safely pull his boot off. But here is the crazy part. When they finally yanked the nail out and carefully removed his boot, the nail had passed perfectly between his toes. His foot was completely untouched. Not a drop of blood, not a single scratch. And yet, before he saw that bare foot, his pain was 100% real.
Section 1. The Great Pain Myth.
How on earth does a guy feel excruciating pain with zero physical damage? Well, to figure that out, we've got to debunk a really old, really simplistic myth, the idea that pain perfectly equals bodily damage. Back in 1664, Descartes came up with his specificity theory, and honestly, for centuries, medicine treated the human body like a simple machine. He basically said pain was a straight-line signal. Imagine a bell ringing at the end of a rope. You get your foot too close to a fire, a dedicated pain pathway carries a signal straight to the brain, and boom, the pain you feel perfectly matches the damage done to your tissue. It's an elegant, super logical theory. But it is fundamentally wrong.
The thing is, these old-school models completely fall apart in the real world. They can't explain paradoxes like our uninjured builder who was in blinding pain without an ounce of damage. And they can't explain the reverse either, like why some people sustain massive, gruesome injuries but feel no pain at all in the moment. Plus, they ignore the fact that painkillers just don't work identically for everyone, and they completely miss the massive variations in pain perception that happen just based on our unique genetics and the environments we grow up in.
Section 2. Pain versus nociception.
Okay, so if pain isn't just a simple damage meter, what exactly is it? To solve this, we have to split our biological hardware from our psychological software. First up, the hardware, nociception. This is simply the neural process of encoding impending or actual tissue damage. Think of nociception as just the raw sensory data from your nerve ending saying, hey, potential harm here. It's just a data point. And the absolutely critical thing to remember is that nociception, by itself, is not enough to make you experience pain.
Now, contrast that raw hardware signal with the official definition of pain from the International Association for the Study of Pain. Pain is an unpleasant sensory and emotional experience. That is huge. Pain is a completely personal, subjective experience. Your brain takes that nociception data, crunches the numbers with your emotions, your past experiences, your current situation, and then basically decides whether to generate the feeling of pain. It can happen entirely without nociception. And because it's a constructed emotional experience, if someone says they are in pain, that report has to be respected every single time.
Section 3. Psychology and Pain Perception. Now that we've untangled the hardware from the software, let's look at how our brain's top-down psychological processing can literally dial this pain volume way up or way down. Look at these two wildly different numbers, 80% versus 32%. This is our second massive historical paradox, and it perfectly proves just how powerful psychology is when it comes to pain.
Back in 1956, a pioneering researcher named Henry Beecher was looking at World War II soldiers and civilians. Both groups had sustained extremely similar, massive tissue damage. But here's what he found. 80% of the civilian group begged for pain medication, compared to only 32% of the military group. Why the huge gap? Beecher realized it all boiled down to their psychological appraisal of the wound. For a civilian, a massive injury was a pure disaster, a life-shattering event. But for a soldier on the battlefield, that exact same physical injury meant something totally different. It meant surviving. It meant a ticket home, escaping the horrors of the war. Their psychological appraisal of the situation literally counteracted the physical sensations of their pain.
We actually see this top-down cognitive processing happening every single day in medicine through the placebo and nocebo effects, which are heavily driven by expectancy. A placebo effect is when you take a fake treatment like a sugar pill and your health actually gets better just because you expect it to. But the flip side is true too, and it's kind of terrifying. The nocebo effect is when you develop real physical symptoms based entirely on negative beliefs, without ever being exposed to a pathogen. If your brain strongly expects a pill to reduce your pain, it will often actively dial down the pain experience itself. Expectation is literally a powerful drug.
But our minds can also act as powerful amplifiers, making things much worse. Two massive psychological culprits here are catastrophizing and depression. Catastrophizing is this negative thinking spiral where you endlessly ruminate on the pain, you magnify how threatening it is, and you just feel entirely helpless to stop it. This is strongly linked to developing long-term chronic pain, and depression creates this terrible, vicious cycle. It actually exaggerates your brain's attentional bias, meaning you are constantly focused on the discomfort. Plus, the social isolation that often comes with depression strips away the support systems that usually help distract you from it. And the data backs us up big time. Objectively, uncontrollable, noxious stimuli are perceived as more intense, harmful, and unpleasant. Experimental studies have shown this over and over. If you take two groups of people and give them the exact same physical pain stimulus, the group that feels they have no control over it will rate the pain as way more intense. A lack of perceived control and feelings of helplessness are actually the strongest predictors of severe pain intensity and long-term disability.
Section 4. The biopsychosocial model.
Which brings us to the grand unifying theory of modern medicine. This is the framework that finally solves our initial mystery of how pain is actually constructed. All the puzzle pieces come together right here. To understand a person's pain, we absolutely cannot just look at tissue damage anymore. The pain experience sits right in the middle of a dynamic puzzle. We have to look at their biology, like genetics and neurochemistry. We have to look at their psychology, catastrophic thinking, expectancy, and perceived control. And we have to look at their social factors. Every person's pain is a totally unique experience built by the intersection of these three major forces.
Let's not gloss over those social factors, by the way, because they get ignored way too often. Socioeconomic status is a massive player. Living in poverty or disadvantaged settings dramatically increases your risk for pain, usually because of higher occupational stress and less access to care. And even social learning, like operant conditioning, matters. Get this. Well-meaning sympathy from your family or getting extra time off work can accidentally reinforce physical pain behaviors, like limping or grimacing. It can actually maintain the pain cycle far longer than your biology alone would dictate. Wild, right?
Section 5. Modern Pain Management.
So, knowing all of this, what's the actual game plan for treating people? Treating only the physical tissue is totally outdated. It's a failure in modern medicine. That's why we have to pivot to multi-disciplinary approaches. And these medical teams have very specific goals. They aren't just trying to magically knock a pain score from an 8 down to a 4. It's much broader than that. 1. Use therapies to help the patient reconceptualize the pain, so it's no longer seen as this overwhelming damage. 2. Improve their actual daily functioning and quality of life. 3. Shift the patient from feeling passive and helpless to feeling active and in control of their life again. And 4. Decrease their reliance on heavy medications by giving them adaptable, real-world coping skills.
And guess what? These psychological interventions absolutely work. Major reviews looking at thousands of participants show that cognitive behavioral therapy, or CBT, provides highly reliable benefits for reducing the sheer distress of chronic pain, and acceptance and commitment therapy, or ACT, is incredibly effective at improving daily functioning. It helps patients actually accept the pain, rather than fighting this exhausting, losing battle against it every single day. Studies show that up to 1 in 2 chronic pain patients achieve clinically significant long-term gains using these approaches.
Which leaves us with one final, pretty massive question to chew on. If pain isn't just a direct alarm bell for tissue damage, if it is actually an experience actively constructed by the unique combination of your biology, your mind, and your environment, how will you change the way you respond to what you feel? Next time you experience pain, maybe take a second to consider the immense power of your own mind. Thanks for joining me on this explainer.